Hello, and welcome to Wired for Change. I'm your host, Amy Yee. Today, I'd like to spend some time on a topic that affects all Canadians, truly, in terms of change and digital transformation that is required more broadly for healthcare and health data. Whether it's about accessing electronic health record information or ensuring seamless care across jurisdictions or service providers, or just leveraging health data for improved patient outcomes, Canada still faces significant challenges when it comes to gathering, managing, and using healthcare information effectively for all of us and across the country in different spots. It's my pleasure to have with me today Glynda Rees. Glynda, I think of you as being kind of unstoppable. You finished your Bachelor of Nursing at the University of Cape Town in South Africa. You've done your Master's of Nursing here at the University of British Columbia, and you're currently working towards your doctorate at the University of Calgary. That's an aside to everything else that you're currently doing as well. So thank you for coming here to be with us today.
Thank you, Amy. I'm just delighted to be here, and thank you for inviting me.
You're very welcome. So let's start with a little bit, more about your background, Glynda, if that's all right. I'm just going to be a bit nosy for a second and ask you just a little bit about, your inspiration. What inspired you to take this path? I know that you do a lot of work in terms of, point of care and how digital affects all of that, and how and education, building capacity in the system as well. So what took you along this path, and what keeps you inspired?
Great question. So I went straight into nursing schools right out of high school. My family was all in healthcare, and it seemed like the natural path for me to take. And I went to nursing school, and then I on graduating, was hired right into critical care. So I worked in intensive care, critical care, fresh out of nursing school, and got amazing supports in that environment. And that sort of sent me on the trajectory of following sort of a critical care path as a nurse. And I did some extra certifications around that. And then that took me to the UK, where I traveled for a long time worked as a travel nurse. And I say a long time, it was a couple of years, but I worked in different critical care units, mostly in central London. And it was a great time. I was young, and it was fun.
That sounds great.
It was a really fantastic experience. What I really noticed in the different units that I was in was how the communication among the different professionals affected outcomes of patients and the whole patient experience. And, this was prior to full electronic health record implementation, but in the intensive care units, they sort of lend themselves to being technologically advanced. So there's quite a lot of technology around, but the lack of communication, or the inconsistent communication between the different specialists that were seeing the patients, was so it was so different in each unit that I went to. So, and as a nurse, my life and the sort of nurses' lives were made much more. We had much better relationships with the rest of the team, and with being able to then provide to our patients what was going on with their condition, and the management of their condition, and the sort of plan of care that was being put forward when the healthcare team was communicating with each other. So not just the sort of primary people like the nurse and the physician, but the social worker, the physiotherapist, the specialists. So that we'd have the cardiologist wouldn't really connect with the renal person, and the renal guy wouldn't connect with the neuro guy, and all these people would all be working on the same patient, but they never seemed to be able to get together at the same time in certain units. And then in other units, they would do grand rounds, and everybody would come together at the same time, and decisions would be made, plans of care would be implemented, and you could see what a different experience that was for the the healthcare team and for the patient and their family and caregivers. And so that really struck me. Out of all the experiences I had, that was something that I sort of really was affected by, and saw the difference in what a difference it made when people were communicating with each other.
And when you say communicating, just to dig into that a little bit, it's all kinds of information about the patient, from updates to decisions that are made to whatever pharmaceuticals might be administered, for instance, and then keeping a record of that, and then just exchanging just sort of qualitative information as well.
Yeah, qualitative information, both qualitative and quantitative, but it was mostly in the actual decisions that were made for the patient. Okay. So, for example, the docs would kind of talk about the drugs that they wanted the patient to be on, but the pharmacist wasn't involved. But if or one specialist would make a decision, and then the other specialist would make another decision, another specialist. So this patient's suddenly on 7 different drugs, and there's interactions, and it's only once the pharmacist finally gets to look at it that it becomes apparent that this is not a good concoction of meds, and then we go back to square one. Whereas if everyone made the decision at the same time, in real time together, then that makes such a difference for the speed of decision making and the efficiency that brings.
Okay.
And the comprehensiveness.
And so that stayed with you.
Yeah.
And it's something that, kind of pervades, what you're trying to do now.
Yeah. And so now in coming to Canada, and I worked in the States for a while as well.
Oh, wow.
And
you're very global.
Yeah. We lived in New York City for a while. And
wow.
I saw similarities there, and then similarities again here in BC, and I worked in an intensive care here for a little while before moving into education, which I'm in now. But I saw similarities in the different units, globally. And then as things started to digitalize, and we brought on electronic health records, and patients have more access to resources that they can go to try and understand their conditions. And we have wearables and our watches and our devices and our Oura rings, and all these things give us lots of data. As well as then in the healthcare settings, there's more advancements technologically as well. So this sort of digitization of information is ideally changing things, because now we should be able to all communicate with one another electronically, because it should be more efficient, because there's no barrier. We don't actually have to be in the same room. We could actually connect offline, etc. But that is not necessarily the case. And we
everything's not magically better.
No, it's not magically better. Not magically better with electronic health records, and even now with AI, etc. So I guess the part that sort of stays with me now is that drive to try and better the system that we have, because I feel like the technology is there. The technology is advancing. It's going to advance whether we like it or not. Generative AI is here to stay. It's not going anywhere. We're not going to be able to hold it back. It's just how do we work to make these technologies work in our favor,
in our actual context, and in terms of the way we behave and work as well.
Yeah,
interesting. Oh, really great. And then, going back to your global perspective for a moment, any observations about Canada or Canada's system, anything interesting when you compare a little bit as someone who's so experienced globally?
Yeah. So I would say there's a lot of similarity, right? Our patients don't look that different. The teams don't look that different. There's a lot of similarity in healthcare, and there's the challenges are similar as well.
Okay.
I think for Canadians, having a universal healthcare system is amazing, right? Like there's so much that that brings to Canadians, but because everything's so fragmented and people work in silos, and there's so much room for improvement. Mm-hmm. So what can we do to make healthcare better in Canada?
Absolutely. And now in Canada, I guess we'd say, many organizations have access to electronic health records now, but, may govern them differently or in isolated kind of ways across the country as well. And how people learn about them, I assume, or how to use them might be quite different as well. And so you have a project called EdEHR. And this is very interesting to me, particularly just because I've been involved in, EHR procurement, as well as, the planning and strategy for adoption. And I've spoken with many others, and I'm on the board of a hospital that has, implemented a new one fairly recently. And so it's very interesting to me that you've got an educational kind of EHR project that is also kind of an open project as well. So tell us a little bit about, what challenge you're trying to address and what it is, really.
Yeah. So what I was seeing in education, so I taught in the BSN programs and the undergraduate nursing program at BCIT. And we have these high-tech, fantastic simulation labs. We've got a new building. It's just, a lot of technology. But we were still teaching students to chart on paper and sort of using paper charting. But then they were moving into practice and in some cases seeing electronic health records. So in BC, we're still in the process of being, fully integrated across all hospitals with electronic health records. But our students were starting to work in going into practice unprepared to work with electronic documentation. So not only, pulling out data out of an electronic health record, but synthesizing that data, making decisions, and then putting data back into the system. So it's a whole process, and it's different whether you're working with paper or whether you're working with an electronic chart. And the decision making is different, the workflow is different. And so how could we prepare our students to work in these environments with electronic health records? And so we looked at different options, and there's several big companies out of the US and, big publishing companies, the big vendors. Some of them have academic and kind of platforms that you can use to provide a form of an electronic health record to students in educational settings. But they were, US pricing, which made us vulnerable when it came to exchange rates, US focus. So we have, Canada is different. Our populations are different to Canadians. We do have just slightly different ways of implementing care. We have sort of much more focus on relational practice. We are very much aware of Indigenous perspectives and integrating that into our teaching and learning and practice. And so we weren't really seeing that in electronic health records. And so in the offerings that were available. So, so we brought a team together with educators across BC, and we got funding from the ministry to work with BC Campus, and we developed a open source educational electronic health record that's Canadian based and that's customizable, so that for example, in pretty much any healthcare setting, education setting, you're teaching students with case studies in simulated environments. And so over years and years of time, various faculty and educators have put together case studies that work for them. And so by bringing in electronic documentation, what we wanted to do with our open source platform is allow for the integration of those case studies. So instead of bringing in external, vendor-driven case studies, we could use ones that were, faculty-driven. And so we wanted the open source platform. And so we looked at very different options and came down to that we need to create this from scratch. And so, so we worked with a software developer who has now taken on the the platform and offers software as a service. So it provides support for programs who are looking to integrate this educational electronic health record into their simulation labs. And so we've been working at BCIT to do that. And it's taken a lot of work, a lot of not from me, from all kinds of other people, many other, the whole team of people who have needed to really come together to look at not only the nursing perspective, but our medical lab team at BCIT has also implemented an educational lab information system as well as part of the EdEHR. So it's been a big project, and it's growing and moving, integrating to more schools, and we're providing a sort of a companion guide to go with it. And
nice, that's amazing. And when did it launch?
Oh, now you're going to get me.
Approximately?
Where does time go?
Within the last year?
Yeah, I would say fully in the last year. But up until then, there's been
some activity,
lots of work sort of done. COVID put a bit of a hold on things at one point, but then it's been going pretty much full ball since the last year.
And is it fairly technology agnostic then?
Yeah. So that's the other thing, is that it's important to us because our students are working with different. In the Lower Mainland, we have two vendors, and so we wanted to make sure that our what they were learning was vendor agnostic, and we kind of make the analogy of it being the training still needs to happen, so you still need to go and learn how to work a specific system, but we're providing the education. And another analogy that comes up is if you learn how to drive. So one thing is, if you're learning how to drive, you can't just do it by reading the manual. You really need to get in there and use it. So that's why we have that sort of integrated into practice. But then also we're teaching the concepts of driving. So once you've got this, you can drive a Ford, you can drive Toyota, a Mercedes. You can adjust it to the actual the version of whatever electronic health record you're using.
That's fantastic. And then, I guess, what kinds of vehicles do you have people been driving with this? So, how's this been integrated into programs that you know of now today?
Yeah, so BCIT, I would say, was primarily the largest integrator and user currently, and then other schools in BC, so University of Victoria, Camosun College, Selkirk, College of the Rockies, Aurora College. So there's different colleges and sites across BC. UBC's starting to explore the idea as well. So everyone's starting to kind of I think what's happening is that people recognize that we need to be thinking about this and preparing our students for practice, but it's quite complex when it comes to adding new things into environments that are already short on staff, short on funds. It's a capacity issue, a resource issue, etc.
You've made it quite reasonable in terms of cost, though, from what I saw.
We've tried to,
Yeah.
And because it's open source, you can access it and download it yourself and use it. But it is helpful, I think, to have the software support so that you can build it and customize it.
And are those, once a case study is in there or a scenario is in there, is that available to everyone, or is it just available to that particular school?
Yes, so right now we have instances of different schools, so they're accessing their own, but some of them are sharing. So there's kind of a process for what gets shared and what doesn't. And there's a lot of discussion around intellectual property. There's a lot of discussion around governance. It's way more complicated than when I had any idea when I first started thinking about this. It was like, well, it makes sense to just create an open source, educational version. But
it's kind of interesting. It really gets into all kinds of things that you hadn't perhaps thought of. So but I mean, that's part of the success and the growth of it as well, I'm sure. Yeah. So that's really exciting.
Yeah. And I think it has so much potential too to help sort of inform some of what we're doing in practice. So, if you look, for example, at medication errors, we could take a simulation of however many people, nurses, nursing students, other healthcare professionals, doing a simulated medication administration activity, and then see where the errors occur, and then kind of extrapolate that out to to practice that. If there's data missing, so because of the data, sort of where data flows and where what are the harms and inefficiencies that occur if data is missing, and could we sort of measure and track that in a simulated environment and see what the impact is.
Mm-hmm. Yeah, some opportunity here to, solve some problems perhaps that everyone, or more than one group is dealing with, or opportunities for standardization once some of that data is in as well. So really interesting opportunity. And then I don't know how many, I don't know how many organizations are, going through transformations from still going from paper to digital at this point in time. But, I know I've spoken to nurses who would rather retire than learn how to use an EHR sometimes, right? And so it sounds like there's opportunity perhaps, within organizations to either improve the level of adoption or to just sort of start off on the right foot, perhaps, if they're making a big change. Does that sound right?
Absolutely. And it's sort of a safe environment to fiddle around with this type of thing and learn, spend some time with a computer in front of a patient. And we, for our students looking at that kind of novice to expert pathway where you're, as a novice, if you're working with an IV pump or a blood pressure cuff or, giving a medication, you're so focused on the task that it's hard to really engage with the patient and the family. And so, but as an expert nurse, nurses can do all those things and assess the patient and the room and have a conversation all at the same time. So if we can help look at something similarly with electronic health records, so that sort of having that computer at the bedside, how do we teach nurses and other healthcare professionals to work in that environment so the computer doesn't come between you and the patient. And if you just turn it slightly and engage with the patient and the family, then that changes the whole dynamic and that comfort level changes. And so some of those communications,
Sounds like there can be lots of impact to the point of care and that interaction and really make a difference for both patients and providers in that scenario.
Yeah. I think so. I think it has so much potential.
Yeah. Yeah, it really does. Well, I think so too. I don't know anything though. I'm convinced.
Good.
Amazing. Okay, and so I'd like to maybe just step back for a moment then to the bigger picture of health data, within Canada. And I understand you're doing some work, there as well on a collaborative initiative to relook at some of what we do with health data. So maybe you could tell us a little bit about that.
Sure. So it was 2019. I worked with the executive board of the Canadian Nursing Informatics Association, and I was president at the time. As I was invited to be on the Pan-Canadian Health Data Strategy Expert Advisory Group through the Public Health Agency of Canada, and through that advisory group, And the work that the group did, we developed 3 reports on kind of the state of data across Canada, and the recognition that there's lots of work to be done, and the sort of main message coming out of that is that we need to do a better job of ensuring that patients have access to their own data, and that healthcare professionals have access to patients' data within boundaries, of course, determined by the patient or the caregiver, and that we move more from a what currently exists as a sort of custodial model of care, where healthcare professionals are custodians of data and researchers. So how can we turn that into more of a stewardship model? So so
maybe for
lots of work.
So some of our viewers who aren't as familiar with custodial versus stewardship as in terms of a model, maybe you could get into that a little bit more.
Yeah, it's so as Canadians and as patients, our data belongs to us, and so it's important that we should know where our data is, who has access to it, and who, where it is shared and what is shared. And in the current model, which comes, I think, from the old days of having a paper chart that, only maybe the doctor looked at, or the nurse, or, and patients didn't really quite know where it was, or
who had it,
who had it, and what certain things meant. But they, in theory, it was always, even then, it was their data, and they had access to that at any point if they requested it. It gets a little complicated, and for anyone who's been in the healthcare system, you can appreciate that if you do want to see your data, even though it's your own, it's not that straightforward, and you don't quite know where it is, and
whether it's been updated or not.
Whether it's been updated, and there's all. I think everyone's got a story or an experience of being in a position where you realize that the healthcare provider that you're working with doesn't actually have access to your information when you thought that they did, or you don't have access to something that you think you should have access to. And so that idea of having kind of a data stewards within the healthcare system that can help navigate some of that flow and that access and sort of management of data, so that it's not difficult to find your information and maybe update it and see what what's there and what the most recent report said, even if your doctor is away on vacation for a month, that you can still access information that belongs to you.
Okay. And so the provider would have someone in this case who would be acting as a steward, or would it be a model that's just applied?
Yeah, and it's not a straightforward model either. And the reason it hasn't just miraculously happened is that it takes some time to figure that out. Like who would be stewarding, and what would that look like? Yeah.
Okay. And so that's one of the things that, was identified as something that, needs to change. Other changes that, were identified perhaps? And I think there have been quite a few probably, but maybe a few of them.
There's a whole report.
Yes.
But the, when you look at the Canada Health Act and, for example, portability is something that falls under the Canada Health Act, which in paper days that, what did that mean? That looks different to now electronic data and sort of digital data. And people are crossing, borders and provinces and territories within Canada. Ideally, their data should be with them. And that sort of portability piece is not happening due to various reasons, or multiple reasons. But, you see examples of that in somebody just within BC. If you're in one health authority and you live in one and you work in the other, and you maybe get in an accident and end up in the emergency room unconscious in a hospital that doesn't fall under your home health authority, then that information is feasibly not there at all.
Yeah.
It's not crossing the jurisdictions. And similarly, of course, if you go into, a different province or territory. And we saw that, with the fires in the Northwest Territories, people needing to relocate to the provinces, whether it was Alberta, BC, they're not only is their data not coming with them, but the providers are not able to transfer that care. So there's also licensing across borders and territories that needs to be revised and updated. And so some of that work is being done now as well.
Okay. Meanwhile, people have to wait for that, I guess.
Yeah, it's not an easy solution, unfortunately. It's going to take time, but yeah, there's lots of work to be done. And so as part of the Pan-Canadian Health Data Strategy delivered the reports, and then that sort of was that. But then there's pockets of work that have continued, and out of the Alberta Virtual Care Coordinating Body, Dr. Ewan Affleck and Terry Price have done some really significant work with that group in Alberta, and put together several reports, three main ones. So interoperability saves lives, data disarray, and disconnected care. And those reports really outline the challenges that we're facing in Canada in terms of data, and the lack of interoperability across systems, and lack of sharing of data, as well as the basic things like data standards. So you can't share across systems if the language isn't the same. So we need data standards for what we do. And for nurses, this is really important because a lot of what we do is not always captured through checkboxes and kind of little data points. We like to write narrative notes, and that's really what captures the essence of a lot of what nurses do in their day-to-day work. And so how do we capture that in a way that's standardized enough that it can be shared across systems, so that it can be measured and recognized as part of the work and the impact on the patients? And, when you think of environments, sort of mental health environments, palliative care, these are environments that are not, they're very different to acute care or intensive care, where the checklist works great, right? You can check things. It fits really well for the most part, not always, but for the most part. But then when you get into environments where there's lots of conversations, and the broader experience of the clinician-patient connection is not even remotely close to anything that can be put on a checklist. So how do you find a way to kind of capture that and share that across systems? So the data standards piece is very important for interoperability. And then there's other things like unique IDs for healthcare providers, so that you can track a healthcare provider across Canada, one that just has the healthcare provider would just have one ID, and that a patient would just have one ID, and that you can track them. So that unique patient identifier and a unique provider identifier doesn't exist right now. So what does that look like? And what we use or create. So there's work being done to do that as well.
But it's something that will have to happen across the country if we want that interoperability.
I would say so. Yes. Yeah.
Wow. Some really interesting opportunities there, though, I think. And I think, your point is a great one around, going from the paper. A lot of the policies and standards that we have today are based on like our former kind of paper world, and the mapping to a digital world it's not a one-to-one mapping in terms of what it was. You can't just make things digital, and it's not just digitization. It's really many, many things that have to change along, with that policy or standard or practice or however it's done. So it is a lot of work, as you say, it sounds like, but, getting to a point where, some actions are becoming clearer, I suppose.
Yeah, I think the biggest challenge is not so much the technology, it's the people, and bringing the people together to do the work. That is a challenge in our sort of current environment. It's historically been. I mean, it's just human nature, right? People have their ways of doing things, and they don't like to necessarily change. And so, working with that interoperability piece is not just technology. It's the people, it's the policy, it's the process that needs to change as well.
And so this, what you're talking about now with the Alberta Virtual Care, group that's starting off in Alberta, but there are things that are applicable, for other parts of Canada as well.
Absolutely. And so we have a group in BC who's working closely with the Alberta group, and we're we've got a group of sort of passionate individuals led by a patient, Claire Stamen, and we're working alongside Alberta and then looking to build I think the next group that's kind of showing interest is Ontario, and then Nova Scotia has also shown some interest. So sort of building out that group.
That's got some momentum then. That's great.
Yeah, absolutely.
And yeah. Oh, sorry. I was just going to ask, how is that working? Like, are you having biweekly meetings?
we have monthly meetings.
Like, what's happening? Are you flying in? Do you have an agenda? Like, how's this work?
Yeah, that's great. So it's fairly organic, but we're also quite structured. So we have a coordinating body. We have terms of reference. We have monthly meetings, and then we prioritize what work needs to be done, and then we developed working groups. So we've got sort of 3 different working groups in BC, and the Alberta group has, I think they have 4 or 5. And so then smaller groups working on actual projects. And so, yeah.
Wow.
And we have agendas and we have minutes.
And is it being funded, or is it purely grassroots right now?
No, it's grassroots right now.
Amazing.
It's grassroots right now. There's a little bit of funding through the Alberta group. They have some funding, but our BC group still, we've just been running for about a year, sort of getting everything together, but growing and more interest being shown. And
wow. Can anyone join, or is there is there an entry exam?
If you care enough about the state of data and health data in Canada, then yes, please join. You know, we're a group. We were kind of using a collective impact model where we're basically a group of people with a vision, principles, measurable outcomes, and kind of coming together because of our interests, and then bringing varied perspectives to the group, but not aligned with our employers. Mm-hmm. So it's not like we're bringing a specific health authority or a specific institution or a specific business kind of approach to the conversation, or representing anybody other than ourselves. But we bring expertise from different areas together. So we have a really nice, diversity of people at the table. And as I said, we patient led. We have an Indigenous representation, First Nations, Métis, not Inuit yet, but working on building the sort of knowledge around Indigenous data sovereignty as well. Mm-hmm. And there's some very interesting. I find it very interesting work that we're doing.
I think it's very interesting as well, and I'm sure others would agree. That's fascinating. I guess curious. What's your perspective on why it's been so difficult to get to this point now? And I know that there's a lot that could be said for the challenges within Canada, probably, but just anything to share about why is it so hard to get here and to get to the goal, I guess?
Yeah, I think it is. I mean, as you allude to, it's multifaceted and it's quite complex. I mean, when we're working in complex systems, healthcare is very complex. We're also, like, if you look at BC, and we've got our, all our different health authorities, and then you look at within each province and how everybody does their own thing, and in each of the territories as well. Mm-hmm. And even within the health authorities, the different hospitals have slightly different ways of doing things, or vastly different ways of doing things. Mm-hmm. And some of that is political, some of it's just historical. It's just the way things have always been. We talk about siloed care. There's another term that I kind of like to use, which is we have cylinders of excellence instead of silos. So, it's not like they're just these silos. Like, people are doing amazing things within their contexts and jurisdictions, and they want to collaborate for the most part. I think there's a lot of, like, if you say we should collaborate, we should get together, generally people will say, yes, great, I want to do that. Mm-hmm. But the actual logistics of doing that are quite challenging, surprisingly. And everyone's sort of at capacity with their day-to-day work and life. And so the sort of just getting to work and getting your job done is hard enough without then thinking about bringing other people on and other perspectives and other thoughts and
complexities of decision making.
Yeah, it just builds and builds, and we know that it's the right thing to do, but it's hard, and it's challenging to bring people together and all agree on the same thing.
Yes.
But with this group that we're working with, we all have agreed that, the vision is to allow data to follow patients, and for patients to be able to kind of manage that and understand what that looks like. And so we have it much better articulated in writing as to what our vision is, but because we're all on the same page and there's no argument anywhere that we want anything different, it's just sort of how do we get there and what does that look like? And so
there's hope.
There's hope.
And you're hopeful?
Yeah, I what's the word? Hopeful. Instead of cynicism, it's hopeful skepticism. So,
that's another good one. I'm going to quote you on that.
We're not going to be, we're not blindly going into the future just full of hope and light and
experience
sparkles. Right? It's like it's not going to be a straightforward journey, but I think it's what Canadians want, and so how do we make that happen?
And so, well worth the effort, I think.
Yeah, if we could actually get there, that would be great.
Well, I'm super excited. That's fantastic. I think that's a great note to wrap up on as well. Although I'd love to pick your brain some more, and you've got lots of good quotes going on this podcast. I think it's a lot of work, but you're working on some things that are very positive and exciting, I think. And so thank you for that. And thanks for letting me deep dive in, back into healthcare a little bit, as well. I think there are lots of things that people might want to be a part of. Do you have any suggestions in terms of, let's say, for EdEHR, how can people get involved? And then for the data initiative as well, how can people find out more and get involved?
So the EdEHR is easy. If you go to EdEHR.org, so EdEHR.org, and you can do a demo, and you can kind of see, there's contact details and a little bit about what the platforms are all about. So that's pretty straightforward if you're interested. And then for the data piece, I would say, at this stage, we haven't. We probably need to figure out a generic email or something, but we're trying to put
logistics.
It's a logistics, right? We're in the process of putting a website together and kind of pulling all that together. I'm happy for people to contact me directly through my email, which I think you'll share. Or do you want me to say it?
Whatever you're comfortable with.
So it's fine. So it's Glynda, Glynda_Rees, REES at BCIT.ca. And then I can, triage where might be the next best person to connect with.
That's great.
In terms of actually moving forward.
The disconnected care executive summary was something that I did, read through, and it's very concise, and it's a very good read. Actually, it's very well written. So I would recommend people at least have a look at that. Yeah. And I know that that's been shared on LinkedIn as well from your profile and from others. So I'll repost that as well. Happy to do that. Yeah. One thing I did forget I wanted to touch on a little bit was just the program, the Digital Health Advanced Certificate Program. Yeah. Maybe tell us a little bit about that before we go.
Yeah. So same sort of thing. I saw in my work after I did my master's, I was sort of introduced to the world of informatics and saw really a need for a program that would help clinicians build their sort of digital health capacity. So that sort of health workforce, kind of educational professional development so to be able to work in these digital environments, and then also prepare people for roles where they're actually working as informaticists or in digital health roles. And for people who didn't necessarily want to do a master's or wanted something else as a competitive edge to get into a master's program, or wanted to do a master's maybe down the line, but wanted to do a little education in between. So We offer a digital health advanced certificate at BCIT, and it's a fully online program. It's part-time. It's meant for people who are currently working, and you can take it in 1 year or spread it out over 5 years. And it's theory courses, and we have a capstone project, and we work closely with the health authorities to make sure that we're delivering relevant, applicable content, and that the capstone projects are kind of working with industry, on a project. So there's a mutual benefit there for students and teams looking for some extra hands to work on a project, and private companies as well. So. We've just been running it for over a year, and it's been quite successful. And we've just been approved to create a AI in healthcare micro-credential. So that's the next step. And there's more coming down the line. It's always growing, and there's always a need for sort of advancing the kind of workforce capacity in this space. So lots to be done.
Incredible. That's really something. What's your favorite thing, about that program?
I think it's the cross-learning that happens with so we bring people from different healthcare backgrounds, whether they're clinicians or non-clinicians, people from different health authorities, people from across Canada. And in the online discussions, our students or learners always we put them in groups of 4 or 5. So there's online discussions that happen, and group projects. And so the learning that has come out of that for the students and for the faculty, and all our faculty are sort of teaching in are working in roles that they're teaching to as well. But that cross-discipline learning and sharing has been really, really a strength of the program, I would say. It comes down more to the collaboration. Like, if you can understand why nurses think the way they do, and why the data scientists think the way they do, and then you can kind of come to a term in a classroom setting, then hopefully you can take that out into the real world and apply it there as well.
Wow, beautiful. I'd love to sit in on one of those classes and hear some of the outcomes of that. Amazing. Well, thank you. I think that if anyone's got an appetite to learn more about health data in Canada, I think this is the episode to watch, because it's a very satisfying episode, and I was very greedy to get more of your insights and experience, Glynda. So I appreciate all your thoughts and your continued work, and certainly going to pay attention to what you're doing next, what this next year is going to bring, because it sounds like the last year was a pretty big one. Yeah. So let's see what happens in this coming year. And thank you all for tuning in to another episode of Wired for Change. Bye-bye.